discuss broadly the idea of obesity as a metabolic disorder versus the idea that it's simply a matter of diet and exercise?
So for all people, the reason that they are obese is because they've eaten more calories than they burn up over a long period of time, and those excess calories are stored in the body as fat. The reason why someone might eat more calories than they burn up over a long period of time is very, very complex, and it involves a regulation of food intake and regulation of physical activity. And so the central mechanisms, the brain mechanisms that regulate that, are not so clearly understood. We're now developing a better understanding of those issues, but it's very hard to access pieces of the brain to study that very carefully. Once you become obese, you develop a whole host of metabolic abnormalities and complications that are harmful to your health. And so having abnormal functions of your pancreas to produce insulin, of your muscles to allow glucose uptake in response to insulin, your blood lipids in terms of triglyceride and HDL cholesterol, and even depositing fat in other organs outside of adipose tissue, like the liver and muscle tissue, are associated with metabolic dysfunction. And those metabolic problems lead to heart disease and stroke, amputation, blindness, have a whole host of serious consequences. So the cause of obesity is eating more than you burn up, but when you become obese, then you develop these metabolic complications. So becoming obese is not a metabolic disorder. It's really based on the regulation of food intake, which is very, very complex.
Obesity is known to be associated with impaired regulation of insulin, blood sugar levels, and so on. And you talked about other organs and sort of a sequelae of effects. What are some of those effects that are less widely known?
So obesity has an adverse effect on nearly every organ system in the body. It can cause increased pressure in your brain. It can have pulmonary dysfunction, sleep apnea, and obstructive sleep symptoms as well. It can cause liver disease, fatty liver disease, which can go on to cirrhosis, infertility, menstrual abnormalities, certain cancers of certain organs, venous stasis, skin disorders, osteoarthritis, low back pain, diabetes, heart disease, stroke, abnormal blood lipids, fatty liver disease. The list goes on and on. In fact, obese people have thicker bones in terms of bone mineral density, but an increased risk of fractures. So it also causes increased fractures of bones as well. And so every single organ system is adversely affected by being obese, and all of them can resolve by losing weight.
All right, so you started talking about fatty liver disease. So talk about how some key obesity-related metabolic processes or processes in the body in general differ for different races, different groups. And I took a quick look at some of your work and saw that you've done some work on free fatty acid reflux, for example. So can you put this in context in terms of different groups?
Yeah. So there are racial and genetic differences, both in the risk of becoming obese, as well as the complications that you have once you are obese. So for example, Asian Indians, and Asian and Southeast Asians are much higher risk of diabetes and heart disease by having a small increase in body weight compared to Caucasians. Hispanics have a much higher risk of having increased fat in the liver and having metabolic complications associated with increased fat in the liver than are Caucasians. African Americans have a lower risk of having increased fat in the liver, but still have a higher risk of type 2 diabetes. So certain populations really are predisposed to more or protected from some of the complications of obesity. The reasons what are genetically causing some groups to have more disease and others less disease are really unknown. We don't really understand why African Americans are prone to having high blood pressure and diabetes, but lower fat in the liver. Hispanics are prone to having more fat in the liver, and Asians are prone to having all the complications of obesity at a lower body weight than are Caucasians.
Have you looked into any cognitive effects of obesity and weight loss?
So that's a very interesting area, because as we get older, more people are developing dementia and Alzheimer's disease as well. And we know that insulin resistance, type 2 diabetes, and vascular abnormalities that are associated with obesity are risk factors for future dementia as well. And cognitive function in people with diabetes is decreased. And so we're actually studying that right now. We don't know the answers, but we're going to see if we can improve insulin sensitivity. Does that improve cognitive function in obese people? And we're going to try to do it by improving insulin sensitivity without weight loss and improving insulin sensitivity with weight loss to see if that's an important factor in improving cognitive function. And cognitive function is not so easy to measure. You really have to go through a battery of difficult tests and maybe doing some special scanning of the brain to help evaluate how the networks are working. But all those are now available to researchers with this development of newer technologies.
Are there some obesity treatments that are more effective than others? And I suppose we have to define what we mean by effective. And what factors affect the effectiveness? So dietary restriction, caloric restriction versus surgery.
Right. So we have a small number of treatments available for obese people today, and sort of a pyramid can be seen as a pyramid. The base of the pyramid, which should be considered for everyone, is lifestyle therapy. Eating less, increasing physical activity. That's very difficult to implement effectively. So even though that's the cornerstone of the pyramid, the cornerstone of therapy, it's the least effective of the treatments that we have available in general. Although some people can respond very, very well to lifestyle therapy, and you never know when. They may not respond this year, but they might respond 1 year from now. And it takes a certain trigger to get people to respond. Some kind of event usually happens where they click, and then they're able to change their lifestyle and maintain it long term. The next level of therapy is drug therapy. So pharmacotherapy is used to treat obesity, and there are 2 new drugs that have just been approved in the last year by the Food and Drug Administration who have reasonable efficacy for helping people reduce body weight. And so those drugs are now available. They're approved and physicians can prescribe them. The top of the pyramid is surgical therapy, bariatric surgery, and there's several different procedures that are approved for treating obese people, and they are the most effective in getting people to lose weight. We have no idea why those procedures work. We don't know why bariatric surgery causes people to eat less food, but it works, and it does it for a majority of patients. As you go up that pyramid, you increase the effectiveness of the therapy in getting people to lose weight, but you also increase the cost of the treatment, and you also increase the risk and side effects of the treatment. So those decisions have to be made very carefully, and you have to consider obesity a lifelong chronic disease. It's not something you can treat for a couple of months, and then if someone loses weight and is healthier, you say, okay, they're cured. It's something that requires lifelong attention, because if you don't pay that attention, the weight will come back again.
So discuss the difference along the same line of treatment or options for people who are at, say, BMI 22 versus, BMI 40. Then it's clear you do bariatric surgery, but then maybe for people who are just over the line, I don't even know if 22 is over the line, but it seems when you're borderline obese, are there fewer options or less effective options than when you're morbidly obese, and then it's clear you need to do this?
So the decision of how aggressive to be with obesity therapy, and by aggressiveness, it's really, you have to think about the cost of the treatment, the effectiveness of the treatment as well, because lifestyle therapy can be very aggressive and very intense and very expensive as well. And it should be directed towards the complications that the obese person might have, the risk that they have for future complications, and their quality of life. And so someone who might be very obese but has a good quality of life, they're able to get around very well, their whole family is obese without any risk of complications, and they've all lived to the age of 100, may not need any obesity therapy, weight loss therapy. Someone much thinner may need aggressive therapy if they're at high risk for disease or have obesity-related comorbidities. So the decision of how aggressive to be with treatment really depends not on how much you weigh and your body mass index, but really your risk for future disease and how much disease you currently have in terms of deciding which is the best approach.
So are there different issues at play? So if you have 2 people with the same BMI and the same risk of associated disease, and then one loses weight by caloric restriction and the other loses weight by surgery, are there different processes in the body and different results, or?
So what you're talking about is actually a controversial issue right now. If you lose weight by diet therapy, reducing calorie intake only, or losing weight with surgical therapy, is there a difference in your outcome? So there is a little bit of a controversy there, because there's some data to suggest that if you lose weight with surgical therapy that bypasses the upper GI tract, which is surgical therapy that's called Roux-en-Y gastric bypass, or biliopancreatic diversion, where the anatomy is rerouted. So when you eat food, it passes the upper part of the intestine and goes directly into the small bowel lower down in the intestine than it normally does. You may have weight loss independent effects in improving metabolic function and causing diabetes to go into remission. That's still theoretical. There's really not great evidence. There's not really hardcore evidence to determine that that's actually the case right now, but it's an area of active investigation. There's clearly major metabolic differences if you lose weight by gastric bypass surgery than if you lose weight by diet alone in terms of your metabolic response to a meal. Because when you bypass the upper GI tract and dump the food directly into your upper small intestine, bypassing the stomach and bypassing the very top of your small intestine, the very uppermost part, you get a very different response to a meal in terms of insulin response, glucose response, and hormonal response. The question is whether that difference in response translates into a better outcome once you've lost weight, or if it makes no difference whether you've lost the weight by dieting alone versus dieting due to gastric bypass operations.
Okay. And then in terms of dieting, so there is the low carb, low fat, high protein versus sort of low fat. Is there indication of whether any of those approaches might be better than the other?
Yes, there is. So there's a million different diets that you can take to treat obesity. The key thing is if you eat less calories than you burn up, you're going to lose weight no matter what kind of diet that it is. A low carbohydrate diet seems to make it easier for people to lose weight and keep it off compared to the traditional, conventional low-fat diet. And so a low carbohydrate diet and a Mediterranean diet as well, which is lower in carbohydrates, certainly lower in refined sugars and higher in complex carbohydrates, has better efficacy in helping people lose weight and keep it off. Although it seems to be harder for people to go on a low carbohydrate diet and maintain it long term, but that's on average. Some people respond very well to a low carbohydrate diet, some might respond to a low fat diet, and you don't know until you try. But low carbohydrate diet is not what it used to be in terms of being a diet that people should not take, an unhealthy diet. Now data have shown very clearly that you can get considerable weight loss with a low carbohydrate diet, and there are no obvious evidences of any abnormalities that would prevent you from trying that diet in people who are obese.
All right. And then one last question. You've been working in this field for a long time. What are there major shifts that you've seen in the landscape, either in terms of research, approaches to research, things that perhaps were considered poppycock and now it's mainstream areas of investigation? Like, how have you seen the field change,
Yes.
both in terms of research and practice?
There have been some major changes in the last 15, 20 years in the field of obesity. The number one change is the discovery of the hormone leptin that's made by adipose tissue that regulates food intake in these rodent models, demonstrating a central mechanism for regulating food intake that's different in obese versus lean animals and different in obese versus lean people. And so that really underscores the neurobiology of the regulation of food intake, which before we used to just think, oh, it's just willpower and a lack of desire to really stick to a weight loss program. But now we know it's the chemicals in the brain. Those chemicals give us willpower, don't give us willpower, and there's strong regulatory mechanisms that involve in us maintaining a certain body weight. Another thing that we realize now is not all obese people are abnormal, that a portion of obese people are metabolically normal. So some obese people, despite having excess body weight, don't have the metabolic complications associated with obesity. We don't really understand why, but why are some people protected from excess body fat and others are predisposed to all the metabolic complications? And the newest thing on the block is quite interesting, and that's the microbiome, the intestinal bacteria, which live within us. We have trillions of bacteria in our intestine. We have more bacteria cells than we do human cells in our body. And those may have a very important contribution to, one, regulation of body weight, but in addition, whether we're metabolically normal or abnormal, depending on the bugs that live inside our intestine.
Oh, that is interesting. So we could have some therapies where it's probiotic therapies, you're pumping certain kinds of...
There's a study in Amsterdam was done where they took fecal transplants, stool from lean, healthy people, gave it through a nasojejunal tube to people with metabolic syndrome, and cured them of metabolic syndrome. by just replacing their intestinal bacteria.
Wow.
And so that's quite impressive when that happens in a small human trial. So this really shows the potential for this kind of approach.